Ani Bojo, welcome and thank you everyone for joining us today for the third webinar in a four-part webinar series, which is titled Supporting Pathways to HIV Prevention and Wellness. Before we begin, I'd like to ask Megan to open us up in a good way.
How miigwech Aaron Bojo Ginawaya Nigonzit Indishnakas Mesquadisine Doden Getchwikodong and Donjiba Anishinaabe Kwe Minwa Wasagadoi Kwe Minwa Shaganashi Kwe and Dao Aurelianda. Good afternoon, everyone. Welcome to our webinar. I wanted to start us off. Unfortunately, Elder Linda Barkman couldn't be here with us today. So I will be opening us up. So I wanted to invite people, if you have water with you, you can use the water to smudge as well, but I'm going to light a smudge here. And as you're smudging, whether it's with your water or with your medicines, I just want to draw our attention and bring about that mindfulness so that we can come together in a good way today. So whether you're using your water or your smoke, if you want to brush that over your eyes so that we can see clearly, see that shared vision that we have, over our ears so that we can listen to one another in a good way, over our mouths so that we can use our voice and use that courage that we have to share our messages and use those kind words as medicine, over our hearts so that we can connect with one another. And I want to offer thanks for each one of you that are here with us, and also hold in our minds those ones that can't be here with us today, and give thanks for all of our ancestors that have supported us on our journey so far. And if you are using water to smudge, it's a good reminder. When we were coming together, a number of us on the call were remarking on the snow that's falling. I'm coming to you today from the shores of Wawasee Yagamik, or the shining waters of Lake Simcoe. And we are getting quite a snowfall here today. And I know a number of my colleagues on the call as well. It's snowing where they are, and that water's coming to us in that way. And when we're in this time of year, it reminds us that we can have that stillness, that snow's coming, so that when it starts to warm up in the spring, those waters are cleansing the lands. And it's that time right now, that time of renewal, the rest, rejuvenation, storytelling, having community, spending time with our loved ones. So I just want to keep that in mind as we gather here today. Miigwech.
Miigwech for that, Megan. So before I invite Megan to give us a bit of background on why this webinar came to be, and before I allow our amazing panelists to introduce themselves, I just wanted to go over a bit of the agenda and some housekeeping. So for the agenda, we're going to hear from Sharia from CATIE, who's going to give us a bit of an overview of some highly effective HIV preventative measures, and which include PEP, PEP, and treatment as prevention. Then we're going to get our panelists going with some questions that we have. The conversation is going to be organic, so please, these are just guiding questions. And then a bit of housekeeping. So we are using Zoom, so we all know that Zoom can sometimes be a bit finicky, and it can, some issues can arise. So if that's something like that happens, please just bear with us. We're going to try to fix it as soon as possible and continue on with the webinar. And at the bottom of your screen, we do have a Q&A and a chat function. So use the chat function to share information relevant to the conversation today, or to just, share some praise to our amazing panelists. And then we do have a Q&A function. So this is where you can put in questions, and we will try to get to all of those questions at the end of our conversation. And so with that, before I invite panelists to introduce themselves, I wanted to pass it over to Megan once more. And Megan is going to give us a bit of a background on how this all came to be.
Miigwech, Aaron. So in November of 2021, a couple of us were having putting together a webinar for Indigenous communities focusing on PrEP and PEP. And we were hoping that maybe we could get a webinar together for Indigenous AIDS Awareness Week in December. And I was chatting with some of our colleagues over at the Ontario First Nations HIV/AIDS Education Circle, or OFNHIKE, and they asked us how we were indigenizing our webinar and what steps we were really taking to ensure that we were engaging with Indigenous. And so with that, we decided to pause with a December webinar and really take the time to think about planning a larger webinar series. So it ended up evolving into a 4-part webinar series that is really looking at decolonizing sexual health, Indigenous sexual health, and being able to have conversations in communities. So if you weren't able to check out that conversation, it's in the archives of Katie's webinar, and that happened in June. And we had a number of great panelists join us to share their experiences and where they felt we needed to go in terms of Indigenous sexual health conversations in community. And then our second webinar focused on the biomedical technologies. So what is PrEP, PEP, PIP, condoms, treatment as prevention. And we had a number of great panelists with us sharing their perspectives on the biomedical technologies. And our conversation today is focusing on how do we access these. So you're in for a real treat with the panelists that we have joining us today. Our next webinar will be later in the spring, so you'll hear more about that, and it will be how do we have these conversations in community, and how do we get the messaging out about the technologies that are available to us. So with that, I will turn it back over to you, Aaron, and we'll get started. Miigwech.
Miigwech, Megan. Miigwech for bringing this all together and building those partnerships for this really important work. So before we hear from Sharia, I just want to give an opportunity for our panelists to introduce themselves, any titles or affiliations you might hold, where you are on the land, and anything else you might want to share with us. So if I can invite Trevor, would you like to introduce yourself?
Sure, thank you, Aaron. And I'm Trevor Stratton. I'm a citizen of the Mississaugas of the Credit First Nation, and our territory is the Golden Horseshoe, Toronto, Hamilton, Niagara area, which we share with the Haudenosaunee Confederacy, the 6 nations of the Grand River, through the Dish with One Spoon Treaty, which also includes other Anishinaabe, and we share this treaty area. It's also covered by Treaty 13 with the Crown. So what else can I tell you? I've been living with HIV knowingly for 32 years. I work with CAN, Communities, Alliances, and Networks. You may have previously known us as Canadian Aboriginal AIDS Network. I was doing a lot of international work for 10 years, and now I've returned to doing more national work as Indigenous Leadership Policy Manager. I'm also on the board of Two Spirited People of the First Nations in Toronto. I'm on the board of CATIE, and also I'm on the board of CANFAR, the Canadian Foundation for AIDS Research and volunteer and activism and that kind of stuff. Thanks, Aaron.
Great. Veronica, can I invite you to introduce yourself?
Sure. My name is Veronica Proper. I'm a nurse practitioner working at the Thunder Bay District Health Unit, as well as at Elevate Northwestern Ontario, providing HIV prevention and treatment to lots of clients in the community. The folks that I work with are primarily vulnerably housed, substance involved. Unfortunately, that is a lot of our Indigenous population locally where I am presenting, and so that is a lot of my client base. And I'm very fortunate and acknowledge that I live and work on the traditional territory of the Anishinaabe people of Fort William First Nation, as well as the Métis Nation. And this is part of the Robinson Superior Treaty. My apologies if any of those words are incorrect, because that's my first time trying to go through that spiel and do it justice. So sorry if I didn't do it justice.
Miigwech, Veronica. Mona, would you like to introduce yourself?
Sure. Hi, everybody. My name is Mona Leapt, and I live in Toronto, Tekaronto, which is what Trevor explained. Is Toronto is on the shores of Lake Ontario, and is the traditional territories of the Haudenosaunee, Anishinaabe, and Wendat people, and many more, and covered by Treaty 13 with Mississaugas of the Credit First Nation and other treaties. I come from settler parents. My parents immigrated here from Egypt, so I identify as a settler, and I acknowledge my settler privilege, and particularly education. So I'm a physician, an infectious disease specialist. I work at the Maple Leaf Medical Clinic in Toronto, where we care for, there's about 10,000 patients at Maple Leaf, and 3,000 of them are living with HIV. And so I've been working there since its inception in 2003. Oh my goodness, 20 years. It's my 20th year anniversary. I have a practice there of about 300 patients with HIV, mainly a lot of women, a lot of couples, a lot of youth, a lot of street involved individuals, like more challenging cases, that have, patients that have comorbidities and different intersecting challenges. At Maple Leaf, I also co-founded the Maple Leaf PrEP Clinic in 2018. And I know that's some of the discussion today. So, I've been, we've seen about 3,500 or maybe 4,000 patients for PrEP since 2018. And we have about 2,500 active patients. I also fly out to Saskatchewan every 2 to 3 months and do some clinics in Prince Albert and the surrounding areas, where my patients there are mainly First Nation and Métis. I'm also a researcher, and my area of expertise in research is women and HIV, including trans health and sexual and reproductive health and rights. So I wish I was at the last webinar also. Thank you for having me.
Miigwech, Mona, and thank you for being here. Last but not least, Sean, welcome.
Hi, everybody. My name is Sean Dukey. I'm a primary healthcare nurse practitioner. I am coming to you from sunny, not really sunny, overcast Thunder Bay. Maybe not getting quite as much snow as you are down south, but we have enough on the ground, so that's okay. And similar to Veronica, I am talking to you from the lands. I live and work on the lands of the Anishinaabe people of the Fort William First Nation, and I also acknowledge the contributions of the Métis Nation in this region. I also identify as a settler. My father is from Trinidad and my mother is British. And so I sit somewhere nicely in the middle of there. We have the privilege of working in an area that is seeing a huge spike in HIV cases. And so I think these are really great conversations to keep the ball rolling. We have been in an outbreak situation in Thunder Bay and in the Northwest region, I think, since 2019. And we're seeing numbers really climbing in this region for sure. So great conversation, really apt. And I'm looking forward to meeting and working with lots of you for sure. And thanks for having me.
thank you all for being here. All very busy, so I'm sure it was hard to schedule this in. And I'd like to introduce Sharia. So Sharia comes from CATIE, and Sharia is going to give us a bit of a presentation on highly effective HIV preventative strategies. Welcome, Sharia. Please introduce yourself.
Hi, Erin. And hi, everyone. So thanks so much for inviting me here today. So as Erin mentioned, my name is Shreya. I'm a health educator here at CATIE. I do want to also mention that, like Trevor and Mona, CATIE's offices and where I also live and work is really situated on the traditional territories of the Mississaugas of the Credit First Nation, the Haudenosaunee Six Nations, and the Wendat. And it's, of course, home today to many, many diverse First Nations, Inuit, and Métis people. So I'm here today, my role here today is really to share a bit of information about two highly effective prevention strategies. And then you're going to hear from our just wonderful panel about pathways to accessing these tools. So I'm going to talk to you about HIV treatment as a prevention tool. And then I'm also going to chat a little bit about pre-exposure prophylaxis, or PrEP. So first and foremost, the most important benefit of HIV treatment is that it improves the health of people living with HIV. People living with HIV on treatment can live long and healthy lives, and it is a literal lifesaver. Also important to keep in mind is that HIV treatment is a choice. A person living with HIV has to decide for themselves if and when to start treatment. And then in addition to this important primary benefit, there is a secondary benefit of taking HIV treatment. And so HIV treatment is also a highly effective strategy to prevent HIV transmission. And this is because HIV treatment can reduce the amount of virus in the blood and other bodily fluids, such as semen, vaginal, and rectal fluids, to undetectable levels. To have an undetectable viral load, people living with HIV need access to HIV treatment and take their HIV treatment as prescribed. Evidence shows that people living with HIV who are on treatment, engaged in care, and have an ongoing undetectable viral load cannot give HIV to their sexual partners. They can't sexually pass it on. They also cannot pass on HIV to their baby during pregnancy and delivery if they stayed undetectable throughout pregnancy and childbirth. Staying engaged in care, being on treatment, and having an undetectable viral load also means having a greatly reduced chance of passing on HIV through breastfeeding. But you know, in Canada, the recommendation is still to use formula feeding. I just wanted to mention that. Having an ongoing undetectable viral load also means people are likely to have a reduced chance of transmitting HIV to people with whom they share injection drug use equipment, but there isn't enough evidence to say that there's no risk at all for this activity. So it's recommended that people use new needles, and all other equipment should also be new every time they use drugs, and share, and to not share, and regardless of their HIV status or their viral load. So that was the first highly effective prevention strategy I wanted to share that we will be talking about today. The second highly effective prevention strategy is PrEP, or pre-exposure prophylaxis. So PrEP is a highly effective HIV prevention strategy that people who are not living with HIV, or people who are HIV negative, can use to lower their chance of getting HIV. The use of PrEP consists of anti-HIV drugs taken by HIV negative people that lowers the chance of getting HIV. So PrEP is a prescription pill containing 2 anti-HIV medications. And so when PrEP is taken as prescribed, the risk of HIV transmission is extremely low. And so PrEP is generally safe and well tolerated, and is available by prescription in Canada. And it's currently, so PrEP is currently only available in pill form, also known as oral PrEP, but other types of PrEP are also in development and being explored. And just to mention, I know Erin mentioned this earlier, there are other highly effective forms of HIV prevention, so PEP, condoms, and harm reduction. And so we're focused today on PrEP and HIV treatment as prevention. So I'm not going to get into those, but if you want to learn more, watch the second webinar in this series or check out the links in the chat. And so with that brief overview, I'll turn it back to our moderators for this panel discussion. Thanks so much.
Thank you, Shreya. We appreciate the highlight of those preventative strategies. As Shreya mentioned, there are some links in the chat. Please check those out. And now I guess we're going to get into our panelists and really talk about how do we access treatment as prevention and PrEP and PEP and PIP. So if I can start with Trevor, I have some questions. Please feel free to, answer them head on, or you can veer off and chat about whatever you feel needs to be chatted about. So as a longtime HIV activist and someone who identifies with an Indigenous person living with HIV, can you give us a big picture view of the knowledge of and access to HIV prevention and wellness tools like PrEP and treatment among other Indigenous communities in Ontario? And maybe what are some of these barriers that communities are seeking to overcome?
All righty, I'll give it a shot, Aaron. As a
Loaded.
person living with, what's that?
Loaded questions.
Yeah. Well, yeah, it is loaded because, as a person living with HIV, obviously PrEP is not for me. But if you think about it, I mean, anyone with HIV is on PrEP, right? We're taking antiretrovirals and it reduces our viral load, so we stay healthy and we can protect ourselves and protect others. But with Indigenous peoples, it's not just HIV where we are overrepresented in the numbers. It's hepatitis C, it's diabetes, it's cancer, it's low economic status. It's a whole long list of comorbidities and the burden of all these intersecting issues that a person is dealing with. And so for Indigenous peoples, trying to deal with a system that wasn't created by us or for us, it's difficult understanding the messages that are mostly created for mainstream and mostly created for gay, white, cisgendered men, and which makes sense. I mean, that's the biggest group of people in Canada at risk are, exactly as I described. But for Indigenous peoples, understanding how HIV and hepatitis C and tuberculosis and syphilis and other sexually transmitted and bloodborne infections, viral loads and modes of transmission, treatment and prevention, it's difficult, not just for me, but for others, understanding the risks and the symptoms, navigating confidentiality, understanding the efficacy of treatments and the fact that the difference between curable infections and chronic manageable diseases, TB, hepatitis, HCV, and many sexually transmitted infections are curable. And then HIV, herpes, and others are chronic manageable diseases. So navigating all of these different, all of this different information is difficult, especially for those whose first language is not English or French, but an Indigenous language. But even the way language is used, the English and French is used differently by Indigenous people. So yeah, I have a story of a good friend of mine in Northern Ontario was diagnosed with HIV, hepatitis C, and TB all at the same time. Within 2 years, this community champion was cleared TB and cleared HCV through treatment adherence. And then he also reduced their HIV viral load down to undetectable levels, all within 3 years. Was a huge success. And then during the COVID lockdown, another pandemic, time 4, for these all these different burdens that I talked about, he unfortunately died from the poison drug supply after that. And this man was a community harm reduction peer champion, providing sterile injection equipment and other harm reduction supplies through peer engagement. And through his advocacy with his peers, it became cool, really cool to know your HIV status through testing and getting on treatment and taking your meds as prescribed to beat back HIV to undetectable status, you know. So we lost a real champion there, but that's a good example of navigating trying to make sense of all this. And this particular friend of mine had a lot of good support from good organizations and a good network of peers. But, you know, we also have to deal with, in terms of getting the information out, there's a lot of gatekeepers out there. And you know, from their perspective, the people living with HIV deserve to be happy. Didn't we bring it on ourselves? Do we deserve to have children? Do people recognize that we are on a journey of health and we have health goals too? You know, and when we do harm reduction and teach about drugs, some people think we're simply enabling people who use drugs and we're promoting drug use, you know. So there's still a lot of barriers like that. If we promote PrEP, are we just encouraging people to have sex? Oh no, don't have sex. Sex education in schools encourage children to have sex, but we know through research that, you know, good comprehensive sexuality education has a tendency for young people to delay their first sexual encounter when they've been exposed to this kind of education. A lot of our frontline community workers and Indigenous especially are not aware of PrEP at all or other new HIV technologies. You know, and ARVs, antiretroviral treatment, first and foremost, is good for the person living with HIV as the first reason to take antiretroviral drugs. But also, of course, it's secondly as treatment as prevention and promoting the campaign around U equals U, undetectable equals untransmittable. That's really powerful. And finally, in terms of getting the message out for PrEP, it wasn't getting out there. And one of our community champions named Harlan Pruden realized that, was really frustrated that non-insured health benefits for Treaty Indians and Inuit people is fully covered through the drug formulary. But many don't even know that it exists. They know that it's expensive and they can't afford it, but they don't realize that word's not getting out. So Harlan did a lot of advocacy and did it in a very pushy way and got in people's faces and really started making a change there. A lot of doctors in rural communities don't feel competent to prescribe PrEP because they feel they don't have enough knowledge, and then try to refer people out, and that's really difficult. And that's another barrier. And you know, a lot of Indigenous people, a lot of my relatives don't understand what information clinics and doctors are sharing with them. When asking my friends, you know, they don't know what their diagnosis is. They don't know the word for their diagnosis or what treatments they're on and what's available. You know, and asking my friend, how did my cousin die of, what kind of cancer was it? Oh, it was that wildfire kind, you know, and just generalized, really not really understanding not only one disease, but that whole multi-sectional comorbidity thing, you know, and navigating foreign health systems that weren't, and conceptions of health that don't fit into our worldview, you know, and this approach of the disease model, that deficit of treating disease and rather than a health model where you're helping people to achieve holistic health. So those are my thoughts on that, Aaron.
Thanks, Trevor. Yeah, I think you know, and that's one of the main reasons why, you know, these conversations have come up, is because mainstream, you know, is just not working for us. But this is an amazing opportunity for Indigenous people to prevent HIV, to live healthy with HIV, and you know, and it takes community and support, and hopefully that, you know, people that are attending these webinar series are going to bring this back to community, and we're going to inspire more advocates and champions, and ultimately improve the health and well-being of everyone in our communities. Miigwech for that, Trevor, is a lot of really great words there. Mona, if I may ask you, how did some of what Trevor was saying resonate with you, and if you can tell us what are some of the main ways that people are accessing HIV PrEP and treatment in Ontario?
Okay, that's a big question. I agree with Trevor in terms of needing holistic healthcare. Also, I agree with Trevor that for Indigenous people, the hospital system, the clinic system has an institutional feel and often can come across as there's institutional violence and structural violence that's experienced in that, and that it feels unsafe sometimes to go to clinic, to go to the hospital. So, we developed a care model. I presented it, quite a bit around the women-centered HIV care model, but really it's just a person-centered HIV care model. And I think what resonates with what Trevor said to me is I think one of the first steps is making patients feel safe and that they're okay. I find that's like the most important thing is they come in apprehensive, but how can you create your environment for each clinic that emanates safety, that resonates with them? Even taking a client, taking an Indigenous client from your clinic environment or your organization environment and walk around your facility, and does it feel safe? Get advice about what should be on the wall. Are there different things that resonate with you? Do training with the staff on trauma and violence aware care. So the first step we believe is acknowledging the pervasiveness of violence and trauma in our society, and doing the work as clinicians to learn what does it mean to practice trauma and violence aware care, which isn't hard. It's acknowledging that violence and trauma is pervasive, and a lot of it is just being a nice person and listening, and asking, what do you want to talk about? What's important to you? And that's, again, person-centered care that's in our model. And then also covering social determinants of health. And then in our model, we believe in integrated care. So I'm an infectious disease specialist. This is the integrated care is easy for, Sean and Veronica, who are NPs, but we're proposing that the HIV care should be integrated with women and sexual and reproductive health care, men's health care, gendered health care, as well as with mental health care. So that's something that is integral to HIV care and should be integrated into all HIV practices and PrEP even, and addiction care in that as well, and opportunities. In our model, we believe that peer support is really important, and Trevor spoke about that. How to access HIV care and PrEP in Ontario. So HIV has the fortune to have a specific department at the Ministry of Health with funding for HIV, the AIDS Bureau. And the AIDS Bureau funds, I think it's about 20 clinics across Ontario, HIV clinics, as part of the Ontario HIV Clinic Network. Those clinics probably take care of, I would say 60-70% of people diagnosed with HIV. Then you have clinics like Maple Leaf that aren't under OCN. I don't think Elevate is it? It is? Okay, there you go. So really I would say access to HIV treatment is excellent in Ontario through the OCN clinics. And then there's the occasional clinic like Maple Leaf that's not part of OCN. But again, like how how comfortable is it for people to go in the door? Yeah, our appointments are scheduled. Can clients make scheduled appointments? Are there settings where care providers can like see a patient if they drop in? We try to do that, but now with clinics being in person and Zoom and phone, that, you know, timing gets difficult. So if a patient drops in, you know, that more drop-in possibility, I think would be good. You know, I'm a big proponent, and I keep saying outreach, outreach, outreach. Like what Trevor spoke about, and Veronica and Sean are going to talk about, there are lots of people that are underhoused, that are on the streets, that have HIV, that are not accessing care. How do we communicate with them to say that we're trustworthy? We want to work with you. And I think that's outreach. So I think that comes down to policymakers, funding, putting money towards outreach. We can really get the rates down. British Columbia did it. The incident rates in Ontario are down quite a bit, but with pockets of real outbreaks like Thunder Bay. So programs like they did in British Columbia, Stop HIV, where they had intense outreach to find cases of HIV and do a frontline on the street outreach, worked there. The treatments are easy. So if someone's diagnosed with HIV, it's one pill a day now. There's like 20 different pills they can take. And I'm also a big proponent of rapid starts. So like Trevor spoke about a case. I have a case. The last time I was in Saskatchewan, it was a new patient diagnosed with HIV, and she came a little bit late, and everyone was really excited because they had a hard time like having her come into clinic. So we did blood work on site, which is huge. I don't know if you do that at Elevate, but being able to do blood work on site so that the patient doesn't have to go somewhere else, trying to have everything on site is really important. And then I spoke to her about starting treatment. And I said, we can do something called rapid start. If you do your blood work, I can call the prescription in before the blood work comes back. I've been given some flack, particularly from Quebec, about, doing that. So I waited for the CD4 count to come back, but then I got a call that the patient was at the pharmacy 1 hour after blood work asking for their medication. Where's my medication? So I sent the prescription, and studies have shown that rapid start, it gives I think it gives control back and power that, okay, I've been diagnosed with this. I can start treatment 1 hour after blood work. And they've shown that if you do, the earlier you start treatment, that actually adherence and return to clinic and retention is better. So I'm a big believer in rapid start, and her CD4 count came back at 350. And, there isn't really much risk of rapid start. You have like the rare patient who's a long-term non-progressor, whose viral load is undetectable and might not need treatment, but it's fairly rare. So that's, I'm a big believer in that. And I was going to say something else, but housing, again, I think I mentioned it. Oh yeah, the other thing that's power, starting treatment rapidly is power, and control, like giving people control, is education. So what Sharia spoke about, it does education, but educating clients, but also their families and the community, because there's so much stigma attached to HIV that I think the power for that is education. So I think getting out and educating that, that HIV is really has excellent treatments now with near normal life expectancies, zero transmission sexually because of U equals U, zero transmission to babies if on antiretroviral therapy with an undetectable viral load. In terms of PrEP, I think Trevor summarized it, has been harder. We actually started our clinic in 2018 because we were waiting and waiting for public health to start a clinic, and they just weren't. So, but I would say now PrEP access is so much better across Ontario than 5 years ago. There is HQ in Toronto that just opened, headquarters for gay and bisexual men and trans women, where they can access PrEP. There's Maple Leaf. There's lots of family doctors in Toronto. But then Trevor spoke about, what about outside of Toronto? So Hamilton has a PrEP clinic with Dr. Woodward. Ottawa has a PrEP clinic with public health. You can go to Veronica and Sean in Thunder Bay. Sudbury has a family doctor. But I think what's hard about PrEP is that how do people know which clinics to go to? It'd be really nice to have a repository somewhere where these are all the clinics and doctors you can go to get PrEP. Because as Trevor said, in our PrEP clinic, we get a lot of patients who have family doctors, but their family doctors don't feel comfortable prescribing PrEP. Or they don't want to go to their family doctor because they feel judged about the STI they have. And they can come to us, and, you know, we see so many STIs, and, you know, like STIs have been around for like thousands of years. We're not getting rid of them, you know? So I'd really like to see that, like a list of where we can access PrEP in Ontario. As Trevor said, for First Nation people, it's covered by IFH, so it's covered. You know, other access to the medication is harder in other settings, but with IFH, First Nation people can access PrEP. So I think we should really see what we can do about promoting that. Thank you. I hope that's helpful.
Thank you, Mona. Yes, very helpful. So over to Sean and Veronica. As nurse practitioners in Thunder Bay, what do you see in terms of pathways to HIV treatment, HIV PrEP? And is there anything that really resonated with you about what Mona and Trevor said? Maybe I can ask one of you to speak to this, and then I have a question for the next.
I can do that, Veronica, if you're okay with that. Okay, cool. Thanks. I think, you know, I'm digesting what Trevor had introduced, and I think it totally resonates with the experiences that we have up north. I think there's a huge overrepresentation of Indigenous folks on our list of people that are living with HIV. And the marketing for a lot of these different services and resources have really historically been directed at cis, white, MSM, who are able to access and have the means and the ability to access services. And we're not really good at meeting the needs of people who are at the intersection of, you know, housing crisis and an addictions crisis, and you know, living with other mental health conditions, and trying to also access care for HIV. And where does it fit on that ladder of priorities for some people who are, you know, struggling with where they're going to sleep tonight, that type of thing. And so Mona talked about also the importance of outreach and getting out in the community. I think that's one thing that Veronica with her street nursing team has really been able to bring forward in Thunder Bay proper, within the city limits of Thunder Bay. But what we need to see is those kind of services available across the north. This is the Northwestern Ontario, you know, we're the size of the country of France. We're over 2 different time zones. And there's about, what, 250, 300,000 people. So it's not a ton of people in this huge, vast land. But there's a ton of HIV, and where there's a ton of HIV, there's also a ton of undiagnosed HIV. Our screening rates are abysmal. And I think a lot of it really boils down to a lot of that stigma around testing, treatment. We have people that, you know, want to access services that come to us in a whisper, asking for PrEP. which is not how it should be. I think that's something that we should be rejoicing. We should really be celebrating. We should be shouting it from the hilltops. You know, it should be a popular thing that, you know, I went and got my HIV test today. I want to get on PrEP because I know that I have a high risk and I am part of a population that has been identified as at a high risk. So we've got a lot of work to do from that perspective. We're trying to build those ladders. We're trying to build some of the access pieces. So with the Elevate Clinic in Thunder Bay, we're working a lot more kind of hybridly, hub and spoke kind of thing. So we have some community partners in some of the in our outlier communities in places like Geraldton and Dryden and Atikokan and even Kenora. We're trying to reach out a little bit to build up some stronger kind of collaboration with some of our other community partners, where we need to be doing some form of like what we would call like a shared care model, where we have our eyes and ears on the ground, whether that's a public health nurse or a primary health care provider or a street health nurse or someone who can help us to deliver those services where we can't physically be. And so we're working on building that kind of infrastructure, but it takes a lot of work. There's a lot of moving pieces. There's lots of different funders. And so, but I think we've seen a lot of growth in that. And that's what we're kind of working towards right now is in terms of accessing both PrEP and treatment, doing that at an arm's length. I think it's still rooted. I think about PrEP and how PrEP is provided. It is still super patriarchal. It really does work in a way that works against some people. We need to get blood work on a regular basis. We need to do these things to monitor. And I think with that comes a lot of barriers for folks on treatment and on PrEP. And so being able to meet the needs of people and find happy mediums in there and keep monitoring where we can, but also making that not be a huge barrier to someone accessing the services. It's a happy balance because there's a lot of risk involved also to giving someone with PrEP who has diagnosed HIV, but we haven't identified it because they haven't been in for blood work in 6 months or 8 months or a year or 10 years. So there's a lot of loopholes in there. I think we're working on it. I think there's a lot of stuff to come, and having chats like this and starting to increase these discussions, increase people's knowledge of the services that are available, I think are really great. I think, what was the other thing? Oh, I had this other really profound thought, but I think I forgot what it was now. Yeah, I'll leave it at that. We're working on it. So hub and spoke model in terms of how we're trying to access some services. And so if you are working in the north, you know, catchment areas are very gray. And so if you can send a referral to Elevate. Our referral form is on our website, which really desperately needs to be updated. We're working on that for sure. But people can access PrEP through our clinic as well. We have a warming shelter, a food bank. People can come in and get a nice warm meal. And they can drop in Monday to Friday with extended hours if you're in the city of Thunder Bay. And you can call our treatment coordinator anytime to get services. We try our best to be available by Zoom or Skype or OTN or whatever it is that works for you. And try our best to kind of make that stuff happen. We do run into some barriers. And so as much as we want to try and be as hybrid as possible, even doing things like really basic CD4 testing for folks that live in the region, we can't access it because a lot of labs can't process it. There's a lot of kind of barriers around collection and timing and stuff like that. So, you know, even the simple basic things like somebody who's living in Geraldton, living with HIV, needs to come take a 3 or 4 hour drive to Thunder Bay just to get their basic blood work. So it really is not an equal process when we compare to our partners working in Southern Ontario. And so we do have a lot of hurdles to kind of jump through with some of this stuff. So I hope I answered your question. I yammered and I forgot one profound thought in there, but it'll come back one day.
No, it's great. And miigwech for all the work that you're doing up there. Sorry, Veronica, were you going to add something?
Yeah, I was going to butt in. Along with Sean's really profound thought in terms of you were talking about what are like pathways to treatment. So I work out of 2 different organizations providing HIV care. So part of what I do is through Elevate, and then the other piece of what I do, my bread and butter, is through the health unit here in Thunder Bay, working with a street outreach team. And in terms of pathways to HIV treatment, I describe myself as a benevolent stalker, because if somebody tests positive for HIV and has been really, really hard to locate, I try to find them and make them my friend so that I can get them on treatment, so that I can get things going for them. Sometimes that looks like me calling the emergency room when I know somebody has arrived there and asking if they're willing to let me come in and have a conversation, bringing the most ridiculous sized cup of tea I can find, and, you know, just basically saying, hey, I hear you got an issue. I'm willing to help you if you will let me. And I feel that there is a tremendous amount of power when I show up and people will say to me, well, yeah, but like, who's going to take care of me? Who's going to take care of my HIV? And I say, hi, I'm Veronica. I'm going to take care of you and I'm going to try and help you. And if you're kind of crabby about it today, that's okay. I'm not going to hold it against you. So those kinds of approaches are really, really helpful and are part of how we're starting to reach some of our harder to reach folks that are living with HIV. That's all I wanted to add.
Thanks for adding that. I do have one more question for you. So as nurse practitioners, this is beyond the scope of your regular practice. Can you give us a bit of an idea of what brought you to this and how did you start?
Do you want me to start, Sean, for that one? So for me, what got me started on HIV treatment and PrEP care for people was looking at folks who had HIV who were not attached to any kind of care provider and weren't on care. And the message that I kept getting was, well, there's substance use issues or they're not housed and you can't get these people to an undetectable level. That's not possible. And I'm just kind of wired to be a little bit of a bullheaded individual. So when you tell me that you cannot do something, I then must find a way to get it done because that's just how God made me. So I basically struck out to make this not true. That's how I kind of got started on it and went, okay, well, tell me about HIV treatment. What's so hard about it? What's so difficult about it? And started reading about it on my own. Then I started attending some trainings. Mona was lovely to provide some training to us in our early days. And then I once I got into it, I kind of realized this stuff is not that hard. We can do this and it's okay. It doesn't have to be, you know, just like a super specialist role. And the first time I had a substance involved patient come back with an undetectable viral load, my team will vouch for the fact that I did an absolute touchdown dance in the office because it's like, there we go, proof of concept. It can be done. And now I'll do it again for the next patient. And just taking complete satisfaction in the fact that it's not supposed to be possible, but guess what? It's actually totally possible. And in terms of PrEP, what got me fired up about that was sometimes in my job, I have to tell people that they have HIV, which is definitely on my list of least favorite job activities to do. And I don't know what other people experience, but for me, every time I have to deliver that diagnosis, the people that I've had to tell anyway, they generally react like I've sucker punched them. Even if they were kind of expecting it or they thought it might be coming, usually it's like a big reaction. I'm just really, really tired of talking to young people under 30, having to tell them that they have a diagnosis of HIV. And that I'm now changing the trajectory of their life. I'm going to try and help them with it, but that from here forward, things are going to be a little different. And I was just really tired of it. So I just, no, we got to prevent what we can prevent here. And this is not that hard. So let's do it.
Sean, would you like to?
Can I just, I wanted to, it's kind of semantics. I think it is within the scope of a nurse practitioner, primary healthcare nurse practitioner to manage, as it is with any other primary healthcare provider, to provide HIV care. It hasn't historically been part of our baseline kind of education. And so for nurses, generally speaking, we need to have the knowledge, skill, and judgment to be able to, that's what the College of Nurses says in terms of defining your scope of practice. And so go out and get the knowledge, skill, and judgment. And that's what Veronica's talking about. So it's not out of our scope. It's not, we're not breaking the laws. We're not extending the legislation out there or anything like that. We're working fully within our capacity. But it does take a lot. There's not like a central go-to place for folks. My other hat is that I work in the educating nurse practitioners, and we have actually worked in HIV and PrEP into basic education for nurse practitioners now, which I think is a huge win, because I hope that this is something that we'll be able to really work with primary care, start sharing this care a little bit, and start to transition folks who are doing really well living with HIV back to their primary care providers, which is where they should be, and focusing on the rest of their life and not just their HIV. And so I think that's probably the nature of how we're going to see things evolve. As people are, just like living with diabetes or any other chronic disease for that matter, you're stable. You don't need a specialist to be doing any of this stuff. You can work with your primary care provider. So, yeah.
Miigwech. And I think I speak for all of us when I say how grateful we are for the work that you're doing up north, and for being so loving and sometimes bullheaded. And hopefully you're going to inspire a lot more folks to uptake this kind of work and really push for it. And yeah, so miigwech for that. We have about a half an hour left. I have another question for you, Mona, if I may. So building off of what Sean and Veronica mentioned about their programs, what role do you think service providers should be playing to increase knowledge of and improving pathways to HIV prevention and PrEP, HIV treatment and PrEP?
Like, you mean like access to care, or advocacy, education, or all of it?
Yeah, like any sort of ideas, because primarily our audience today is service providers, nurse practitioners, clinicians. What do you think that they could be doing to increase this knowledge in their communities, working with Indigenous people, and improving these pathways in First Nations communities or cities that have high population of the First Nations people?
Sure. I think first of all, having HIV testing, we didn't talk about HIV testing. Maybe you talked about it in another session, but HIV testing is a really important part of the puzzle also in community. And then, for care providers to always have like HIV testing and PrEP on their mind. So if person is having sex, right, they, a discussion of PrEP should happen, in my mind. We have a lot of cases of STIs right now, sexually transmitted infections, across the country. I think in any case of an STI, PrEP should be, an HIV test should be done. Hep C, like all the STIs, STBBIs should be tested. So I'm all test frequently, and also consider PrEP. The other thing is to kind of like what Veronica and Sean said. It's so easy. Like it's really not hard. So it's for both PrEP, it's 1 pill a day of mainly Truvada, which is covered by IFH. 1 pill a day. And we try not to tell people this, but the original PrEP study, IPREX, showed that if you only took 4 of those pills in a week, the PrEP still worked. Can you believe that? So even if there's non-adherence, it has to be more, you're missing more than half your doses. So it works. And but what you have to keep on top of is what Sean brought up, is the HIV test, to make sure that you're not giving inadequate treatment if someone does develop HIV and they could develop drug resistance, and then a creatinine, because the Truvada can affect the kidneys. But we've seen 4,000 patients, and we have had I had one patient with Fanconi's, which is the severe kidney issue that Truvada can cause. 1 out of 4,000. It's not as common as we think. the kidney issues. So I think it's easy. I think it's just easy. Get, you know, Daryl Tan led CMAJ, Canadian Medical Association Journal guidelines on PrEP. Read them. That's what I did. And I think the one thing is I'm a big believer in nurse practitioners and nurses because they're more readily keen to learn new things. Doctors are like set in their ways. I don't want to do anything new outside of my so that's one thing I love about more and more nurse practitioners should be at the front line in primary care. Also, nursing training has anti-oppression training, while medicine doesn't still. And actually, I didn't tell you, but our PrEP clinic at Maple Leaf PrEP Clinic is a nurse-led clinic. So there's blood work. They get the baseline blood work. So like I could tell you right now how to do PrEP really easily. You do baseline blood work with a creatinine and then all the STBBIs, HIV, hepatitis A, antibody, Hep B, all the antibodies, surface antigen antibody, surface antibody, core antibody, Hep C antibody, syphilis blood testing, urine for chlamydia, gonorrhea. And then we like to do a throat and rectal swab for chlamydia, gonorrhea, because if you don't do the throat and rectal swabs, you're missing half the cases of, and we don't do any other testing. We don't do a CBC. We do not do liver enzymes because they will come back as abnormal. So we just do the creatinine and a urinalysis baseline. Then we have the visit. We don't deny PrEP from anybody. And then the follow-ups are every 3 months. And that's it. And then every 3 months, they get creatinine, all of the blood work, the urine, the swabs, and a new prescription every 3 months. We don't wait for the HIV test to come back before we give the next prescription. If they're taking PrEP, it works. We know that HIV test will be negative. And then that's it. I think the thing that some family doctors miss to do is the swabs. So we see that a lot. And then we also provide sexual health vaccinations. We give Hep A vaccine, hepatitis B vaccine, and HPV vaccination. So that's it. I just taught you PrEP in 1 minute. That's how you provide PrEP. And then HIV treatment, 1 pill a day. And it's even easier. You only have to do blood work every 6 months. So I think, it's really easy. So if there's care providers out there, read the guidelines, speak to Veronica, Sean, myself. We can, you can do preceptorship. So if you want to come to the Maple Leaf PrEP Clinic, we have directives. We'll send you our directives. So if you want to have directives for nurses to do your PrEP, we'll send them to you. Doctors can also write directives for pharmacists. So in Saskatchewan, we're a little bit different. We have less like most care is given by nurse practitioners and nurses, but we have less. So actually the pharmacists do a lot of the care. And so you can write directives for pharmacists just get out there, learn how to do it. And I think we have to do more education. People like Trevor or, Megan, Sharia, into community. So I do clinics in community. I go to Montreal Lake, Cree Nation in Saskatchewan. So we're trying to do that, is go into community. It takes steps, the chief and council have to approve you coming into community. There's often ceremony done when you come into community. But that also, I think Ontario is not doing enough of that, going into community.
Yeah, amazing. And that's why we're hoping that that's going to change very soon. That's why Oahas is here. They're amazing. Trevor, if I can ask you another question. So what knowledge and understanding do Indigenous and non-Indigenous service providers and clinicians need to bring to this work when working with Indigenous people who are living with or at risk of HIV?
Such heavy hitters. I don't know how I'm going to follow up on what's just been said, but of course, harm reduction is extremely important, and the non-judgmental approach and the recognition of the, this division, this divide between service provider and patient, right? There's a power imbalance, and it's many, especially Indigenous people, many of us, like myself included when I was younger, didn't recognize my own personal agency, and that our community service agencies, our job is to put ourselves out of work. And it isn't us and them, we're all human beings, but there's this classism that exists in the service provision often. Like a big sign on the door of the Indigenous Youth Center that says, anyone found to be under the influence of alcohol or drugs will be, kicked out or whatever. But it's not for the staff per se. I was there to do a presentation. I just smoked a joint and had a shot so I could relax and be more myself and be funny and engaging. And, no one even looked at me. I just walked through because I was considered, us, not them. So I wanted to tell that little story. It really gave me a bit of an education there. But engaging with the target group, asking the people what they want, consulting widely with the key affected populations, like people who use drugs. What do you need? People experiencing houselessness or who are underhoused, sex workers, two-spirit people, and trans people. They all have different needs. And if you don't ask, we're just guessing or looking at reports, right? Instead of listening to the people. I think, and Mona touched on this, Indigenous people expect a human connection with service providers, even doctors. And then we want to be treated as important, not as an irritant or some kind of inconvenience. And I've heard some professionals talk about, oh, they're hard to work with, they're hard to house, versus, stepping up and asking them, what is more important, what is important to them? How do you want to be treated? But what else is important? Because we're here for HIV, but maybe something is more important. So being more human, and the concept of professional distancing, it doesn't really, most of the time, isn't working for Indigenous people. Engaging key affected populations in providing services, making the space welcoming, like Mona mentioned, that cultural safety. People walk in and they don't see elements of their identities there, like a trans person coming in, it looks like a law office there with nothing saying, no rainbow flag, nothing. And there's like 3 easy steps. Welcome, you're welcome to come in. We've made a place for you. The second thing is we have already made a place for you. And the third, to now make it your own, and those 3 steps help to make it much more inviting if people can see stuff in there. All these new technologies, not just PrEP, but long-term injectables, taking an injection instead of pills, taking an injection that's slow release every 2 months, HIV self-testing, multiplex testing, where you're testing one-stop shopping, where you go in and you have a test for 2 things or 4 things all at once with, and getting all those results. Harm reduction vending machines are coming, the Good Health Box, 1-a-day antiretrovirals, treatment as prevention, and getting the word out about U equals U is really important. In supervised injection sites, a lot of us, the word's not getting out for Indigenous, especially in remote and rural communities. If they know things about HIV, they don't necessarily know the newest technologies coming out. So we need these campaigns and partnerships between local, regional, national, Indigenous, and non-Indigenous allies, and these partnerships to be equitable. And contextually relevant messaging for Indigenous peoples with localized worldviews, and not taking that pan-Indigenous approach, because each of our communities is quite different. And our languages are different, but even the way Indigenous people use English or French is different than the mainstream. Like in research, we're looking for a key informant, but in many of our communities, that means someone who turns you into the cops, So if there's a message that I could give, it's consultation, 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 asking people and building it into the budget. these consultations and building into the budget, implementing and piloting new ideas from communities. Some of the best interventions have come from community members, and trying and failing, piloting these things, that is research, learning from when things don't work, well, doing it better the next time. And we need to tell the story of the happy endings, the potential happy endings, like what happens if you do and what happens if you don't. Because we have a right to hope, people living with HIV. And diagnosis doesn't have to mean gloom and doom, but often it does at first. And this can really open the door to a healing journey for us. Learning about the most important day is when you were born, and the second most important day is when you understand why you were born and what your unique role is as a helper. Our roles, our responsibilities, people need us. And that reciprocity between giving and taking in our communities, and belonging and connection is really important. I think that's what puts people at the most risk, is when they don't feel connected. They feel like they're all alone, no one's there for them, they're not a part of anything, why am I here? And helping to build people up, to set their own health goals and walk with them without judgment to help them get at these goals. Their goal could be abstinence, so help them with that. Abstinence is a part of harm reduction if they choose it. It could be switching from injecting crystal meth to smoking crack, a small victory along a long healing journey. Addressing stigmas and discrimination starts with our own service organizations and our own clinics and our health system, and then it extends into the general public. But we have a problem with stigma even within our own service provision. One-on-one support is very important, not only with professionals, but with mentors and peers. But it's also important that group support, where key affected populations can come together and develop a sense of community and community building, and that sense of belonging and having others to talk to. But not only focusing on HIV or sickness and death, but social activities that don't seem connected to health interventions. But building community is an intervention that can lead to holistic health and well-being, or just raise the quality of life for people living with or at risk of HIV. And gay dating apps like Grindr and others, after pressure from the HIV sector and a lot of lobbying and advocacy, many of them have integrated prevention mechanisms into their systems, like being able to click on options in your profile outline to show that you're on PrEP, or that I'm HIV positive, but I have an undetectable viral load. And U equals U and treatment as prevention, and they're promoting messages and links, and they send you messages about that. And many people who are HIV negative mention when they had their last HIV test. And I'm not sure if dating apps for people who are looking to have a date with members of the opposite sex are doing this, but it sure seems like a best practice or a wise practice for the private sector too. Discussions on drug use and sexual activity can really feel scary and unsafe for Indigenous peoples. And this is why we have to walk with Indigenous people on our journeys, right? Walk beside or behind, but not in front, like a bull by the nose. And a non-coercive support is so important, and figuring out what are their priorities, because it's not always HIV that they want help with, that they're coming in for, and helping them to achieve those priorities. That can open up the beginning of trust. That's starting where they're at, right? Trust is a continuum, and Indigenous people have been lied to and cheated historically. And community-based organizations, just like clinics and others, we can be seen as just the system that's hurting them, that institutional violence. But we have to ask ourselves, community-based organizations through social services, sometimes we're just helping to maintain the status quo and acting as a buffer to the ruling elite, controlling this capitalist foreign system where the gap is growing quickly, more and more quickly, between the rich and the very poor. Providing dented canned food with no labels can keep people locked into the very bottom strata of power and privilege, or being perpetually locked into unpaid volunteerism or very low paid work. That's service provision can be like that, where we're just supporting the system. But if we're also working towards social change and working toward putting ourselves out of work, that's ideal. And ideally, we're doing both social service while working on social change. and helping people to recognize their own self-agency. You know, like my own personal story, I didn't recognize that I had the power to advocate for myself. And I was using a lot of social service agencies because I didn't recognize my own agency within. And it was community that helped me to come to the realization that I did have personal power and the ability to navigate the system to advocate for myself. But that was through building personal support networks and of friends and family and community and other peers and helpers or colleagues and volunteers. And, you know, that connection, what is my role and my responsibility? How can I respect myself and protect myself? And that understanding between two human beings can lead to how can I respect and help protect others, you know, that role. So that's what I'm thinking of when you ask me that question without taking up more time.
Miigwech, Trevor. Yeah, that's why you're my hero. You're amazing. Such a great mentor as well. Miigwech for all the work you do, Trevor. So we have a few questions from the audience, and I'm wondering if maybe I can, before we get into those, I just want to ask Sean and Veronica one final question. And it's for any other nurse practitioners who may be joining us today, or any non-prescribing service providers. How can they support improved pathways to prevention?
I mean, I think the big thing is knowing what your local resources are. So if you are a prescriber, knowing that there are people that you can turn to for support to start prescribing yourself. There's lots of education and resources out there. OHTN is a great place to start. BC's got a ton of education, online courses and stuff you can tap into as a prescriber to learn how to manage this stuff, because it's really not that hard. Take home message. And then I think as a non-prescriber, regardless of what your role is, I have two thoughts with that. One is I've been a nurse for 10,336 years. And when I went to nursing school, I remember a teacher telling me, one of my professors saying, never work harder than your patient. Because you're going to burn out. You can't spread that. But, you know, I really find that that is not the truth. That can't be the truth. And that can't be the truth when you're working with folks like this. It's that difference between equity and equality. You need to work harder than your patient sometimes to meet their needs. It sucks sometimes because you really are working super hard for people. But that is the only way that we're going to break down some of these barriers and really kind of meet people's needs. And so we have to be really creative with how we're approaching work, I think, from that perspective. And that goes across the board. Not necessarily just nurses, but anyone that's in a role where you're supporting people, especially folks who are struggling, the people that we're talking about, the population that we're talking about today, that need people to work harder than them, to help them to gain that sense of community, to gain those supports like Trevor was talking about, so that they can find their own agency. They got to get to that point. And I think that sometimes people just need to be shown how to get there. And that takes a little bit of work. And sometimes you're working a lot harder than some folks, I think. And so knowing, regardless of if you're a prescriber or a non-prescribing provider or a support or a family member, is knowing the resources that you have locally available to you at your fingertips that you can tap into. And if you don't know those, try and find out, reach out. There's lots of different ways to find that. But if you can point someone in the general direction, you don't have to do that HIV test. But if you can point them in the general direction of where they can find it, that really does help to break down barriers and give the, pass on a little bit of autonomy to an individual to make those decisions and start to take some of that stuff over themselves. That's my thoughts there.
Yeah, I think I would just add, it's really important to just make it a routine part of the conversation to talk about HIV in a non-stigmatizing way and talk about PrEP and just kind of offer it. I tend to just kind of rattle it off in terms of my routine screening and testing practice. And this is also one of the services that I offer. If you want to take advantage of it, if you want me to tell you a bit more about it, I can. If not, just know that I can do that for you. And, or I can find somebody else who can do it if you don't want to talk to me because, the white lady in the clinic is not okay. Whatever that looks like for people. In terms of non-prescribers, what's most important to know is PrEP is out there. It's effective. and then figure out who's nearby, who's going to help you out, who can prescribe it or who can offer it. And if you form a trusting relationship with that person, that is of critical importance. I can't tell you how many patients I've had brought to me that have been brought by a non-medical person who have reached out, built a relationship with somebody, and then said, I really need you to meet my nurse practitioner because she's really great and she'll swear all day long and she'll take good care of you and make you laugh and she won't make you feel bad about whatever is going on. I think that's tremendously important. So knowing that it's there and then providing access to the trustworthy human.
Amazing. Miigwech, I have a few questions from the audience. Some may be a quick yes, others may be a little bit more in depth. So it was mentioned where to go for PrEP education. Where can nurse practitioners go for HIV treatment education, and how can we engage in that?
One of the easy ways, if you want like easy education, OntarioPrep.ca has an excellent like 1 hour lecture that Dr. Woodward put forth on PrEP. I think he was one of the first people I listened to talk about PrEP. And it's very easy to understand. And if you're a big nerd like me, then you find the mechanisms with the pharmacomechanics really exciting and interesting to figure out what's actually happening in the background there. Then once you find out how easy it is and how well tolerated it is, it's really quite exciting because PrEP is so good. It's like 95% effective at preventing an HIV transmission if somebody has sex with a partner who has HIV, who has detectable viral load, if they've had it for 7 days on board. This is assuming that we're talking about anal sex here and the anal tissue, but still, it's not a huge window of time to develop something that's super duper effective. And we give vaccines and promote the crap out of vaccines that don't have the same effectiveness. Not to say that you shouldn't get your vaccines. Please get your vaccines, but do the thing that is effective and takes care of your body and prevent the problems you can prevent, because there are so many problems in this life that you cannot prevent. Don't invite more trouble into your life. Prevent the ones you can.
There's also a really quick course on the BC Center of Excellence for HIV Care for PrEP for prescribers. It's a little bit longer than the one on the Ontario PrEP course, not quite an hour. It's a few modules, but it works you through a little bit more of the intricate details. So if you have a bit more of an interest in it, it kind of goes through a lot. And it's free, and you can just sign up, get yourself a password, and do the course.
I think I can say that once we've uploaded this video to the CATIE website, that it gets sent out to everyone. And I think we can try to make it a point to share some of these resources, as well as some of the resources that were shared in the chat. And we will reach out to our panelists just in case they do have any more recommendations, and we'll be sure that we get those out to everyone. So this is last question, pretty important one. How can we get PrEP available to isolated communities?
I think if you're talking about, First Nation communities that have a nursing station or anything like that, I think that would be your first step, trying to increase access there. If you can't access it, or if there's, if you're worried about things like stigma, that type of thing, then we start looking at some of these other models. There are a few online PrEP source places. I think most places are going to need you to do some blood work and stuff like that. So you are going to probably need to show your face to a local nursing station or health center, or down your closest public health unit, something like that. I mean, if you're in the Northwest, you can totally reach out to Elevate. If you Google Elevate NWO.ca, our contact phone numbers there. The website needs to be updated. I apologize about that, but you can definitely call us, or get people, if you're working with individuals who you think might benefit from being on PrEP, get them to call, and we can work out a way to deliver that hybridly. I think there's similar models are available kind of across the board that can kind of gain you access to that. And we would just work with local healthcare providers to make sure that we got the information that we need to get you on.
Great. And sorry, one more question. This may follow into the previous question of PrEP education, but will it be possible to send out a PDF copy of medical directives for nurses, pharmacists, for HIV testing and physician treatment pathways?
I don't know that we have one that is in a state that's pretty enough that other people would want to read it yet. We know what it is and what it looks like, but as I say, it's not pretty. But there are many that exist.
Yeah, email me, and if anybody wants the directives, because it's better to email, and if I email you directly rather than posting them, because the issue with directives is they have to be updated every year. Like someone does need to keep up on the literature and update directives. So if you email me, I will email you and give you that caveat that these are the directives as of January 7th, 2023. And that's the one thing about directives. So I put my email there, just email me, and I'll just ask my nurse, Greg, to forward them to you. So we have them in a zip file and we'll do that.
Amazing. So Shreya, Mona, Sean, Veronica, Trevor, I just want to thank you all immensely for the work that you guys do in community. It's been a pleasure to have you here for this conversation. And I look forward to seeing you all in community soon. And with that, I'm just going to thank all of our participants for joining. We hope that if you learned something today, you take a look at the previous webinars, share these webinars within your communities, and hopefully people will begin to uptake this information a little better. Our next webinar is going to be in the spring, and it is going to be focused on implementing these strategies and what's going on in community that it's supporting these. And so that's sort of what our fourth webinar is going to be about in the spring. And yeah, I guess with that, I will say thank you. And I'm going to ask Megan to send us off in a really good way. And I hope everyone stays safe and healthy and happy, and have a great new year. Megan.
Chimigwech, Erin, and chimigwech to all the panelists. Since we opened in a good way today, I want to say chimigwech and give thanks to all of our ancestors, relatives who've been here with us on the call today, guiding us as we move through this heart work and sharing all those powerful messages that you've learned from each one of our panelists. The snow's really coming down here, so I think I'm in Aurelia. I don't know what the weather's like where you are, but it's just a reminder to me, as human beings, we're over 70% water, and it's so important for that water in our bodies to move as we live. And many of our panelists here have talked about that good life, that life we want. And so as the snow's coming down, it's reminding me, to take in that water, help those waters move through my body, offer those prayers and give thanks when we can access that clean drinking water. And really just reminding us about our connection to life. So with that, I want to wish you all a wonderful afternoon or whatever time it is where you are. Please stay tuned for our next webinar. And thank you all for participating in these conversations in community. And don't hesitate to reach out to us. Oahas and CATIE are working on some of the resources that people are looking at so we can advocate for increased access to pathways, doing some of that work in community that a number of our panelists have talked about. So if you are looking to access PrEP and are looking for a resource to go to your general practitioner, whether it's your family doctor or whatnot, and are looking for some guidance on how to do that, we're hoping to come out with some resources that will help you with those conversations. So chimigwech, bamapi everyone, until next time.
Thank you.
Thank you. Good night.